Our next speaker is Dr. Walter Wodchis, and he is an associate professor in the Institute of Health Policy Management and Evaluation at the University of Toronto, a research scientist with the Toronto Rehab Institute, and an adjunct scientist with ISIS, as well as a principal investigator of Health System Performance Research Network. So, Walter, would you please take us through health human resources and health system organization, performance, and evaluation?
So on a day like today, I am clearly the new kid on the block. I was still an undergrad when ISIS started, and when the Canadian dollar hit the all-time low, I went off to the United States to university. But I'm back here now, and I'm going to talk about work that went mostly before me. So credit goes to others. Any inaccuracies are probably with me in summarizing the work. And I'm going to take a perspective on this that was highlighted earlier today, right at the CEO panel, that talks about the contrast or the parallel program looking at being ministry relevant and policy responsive and creating scientific endeavor in the health system. And this is how I think my depiction of partly how it works is questions come out of the Ministry of Health, Mo Block and others, leading, and they have ideas, they have questions. ISIS will develop answers to those questions, but in coming up with those answers, it spawns a whole new creative enterprise of new and interesting scientifically important questions as well, which leads to new grants. And that information and knowledge, I think, winds its way back into the ministry for informed policy decision making. And I'll go have an example here of LIN boundaries and defining LIN boundaries, leading to new work on different ways of thinking about the constellation of healthcare providers, organizing around patient care, and how that led to physician networks, which is now finding its way back into the ministry. But I'll start with physicians. So a couple of the early pieces of work in 94 and 96, practice patterns of physicians in Ontario. And the focus at this time, as others have mentioned, that it was really on billings. Ontario was in recession and the government was responding with caps and delisting of services. In following up on these ISIS publications, there was also another CMAJ publication by Ben Chan that outlined practice patterns specifically of high billing doctors, and that led to a few anxious moments for Ben as he started receiving hate mail. In 99, there was this physician supply of physicians, and not only headcount, but talking about new ways of measuring full-time equivalents and resources that are actually available to handle care in Ontario. And because physician supply was such a challenge, there was a very complex model of the AIDIN model, which was Ben's first child, assessing doctor inventories and net flows. And it was used to predict physician supply, still used. All kinds of different arrows of inputs and throughputs in the different ways that international medical grads would come in. And it ended up being so complicated in the bottom slide, I couldn't even put it out there. In the next period, 2004 to 10, we started seeing the new emergence of many new practice models of physicians in Ontario. And this graph here shows the emergence of FIGs, FINs, FITs, and FOs, among others. But clearly, the blue section here that you really see appearing, that starts to show how many more people are involved in networks where physicians are receiving a capitation payment for their care. The reds denoting still primarily fee-for-service. And this spawned all kinds of new research. Rick Glazier and others have been working on, which is to understand who are in the different models and what kind of care are they receiving, and how is this really impacting on the care received by Ontarians. Most recently this year, we're back to compensation and deja vu all over again, as the very first speaker said today. Once again, struggling with the deficit and being concerned about physician payments. And this graph here is showing how the payments have really evolved in the last couple of years, and salaries are really going up, but due to primarily these non-fee-for-service models and basis of payment. And now it's to understand sort of where that money is going and how it's impacting on patient care. So that's one section. I've got a couple more to go. Around evaluation. And I'm going to cover off here examples from emergency department use. In 2001, ISIS published an Atlas of Emergency Department, and this would be the first in what Michael Scholl might refer to as shining the light, turning on the lights to see what's happening in emergency departments in this particular example. This report looked at ED volumes and utilization, how they varied by patient demographics and location. Again, this spawned new areas of research and inquiry. For example, looking at, in that initial report, some of the ideas being they found the number of physicians working in emergency departments had been declining over this period, and at the same time, the impact, the amount of use in emergency departments was still quite high, and so actually we're seeing increased workload among physicians. So what are the impacts of that? And what are the impacts on wait times, for example? Another thing that initial report highlighted on was the variation in practice patterns in the use of emergency departments. And we see here, just as everybody goes on holidays, people start showing up in the emergency departments. The work that looked at the workload and understanding the impact on wait times really had very important implications. And as much as the Atlas raised the issue of ED closures, the first question to be addressed was really, does hospital restructuring lead to ED overcrowding? And when the answer to that came back as yes, well, what are the implications of that ED overcrowding? And that's where the research from ISIS really identified that ED overcrowding and longer wait times has important impacts both on the death of people as well as admission to hospital within a week after. Pretty well a twofold increase in readmission to hospital after leaving an emergency department that had long wait times, and almost that again in mortality for those same individuals. So that was kind of phase one. Phase two focused in more specifically on issues of care related to AMI. So this is getting into more very detailed research that can only really be done in a focused way. And a series of studies found that ED overcrowding meant that being in an ED wasn't associated with low volume of patients, but really had led to triage problems. So if you went to an emergency department where AMI patients were not seen very often, the physicians were not as used to managing your care, and it could lead to serious consequences and a higher risk of negative outcomes. More recently now, ISIS is into a third phase, and this is really around evaluation of interventions in the province. So now the province of Ontario has looked to a number of new initiatives, some of these being the ED performance improvement programs, another one being the Pay for Performance program, and finally clinical decision units, which are a pilot program intended to mitigate overcrowding and address some of the challenges with wait times. And ISIS will be very involved, both presently and going forward, with the evaluation of these programs. So I'm going to step back now and have a very high-level population view of health use in Ontario. So the third example today is the creation of Ontario's LHINs. So these here are the hospital service areas that were developed at ISIS that examined the individual travel patterns of all Ontarians receiving health services in hospitals. Hospital service areas were collections of census dissemination areas, very narrow pieces of geography whose residents received most of their care from the hospitals within these service areas. And then the conglomeration of these hospitals created the LHINs. Regions where residents received most of their tertiary care from hospitals within the LHIN area. So LHINs were also based on hospital-to-hospital referral patterns of tertiary care. And they're an excellent way to have population-based management, planning, and evaluation in the health system. But LHINs, as it turns out, are generally too large to be particularly effective in quality improvement, where local providers need to become highly engaged in managing their own patient populations. And I think about this when the average provider in a LHIN thinks that everybody in the LHIN is somebody else's patient. They're just so large. And so there needed to be a more appropriate area for clinical quality improvement. And this spawned new research and new ideas that led to the creation of health quality networks or physician or patient-centered networks, as they might be referred to. And these are multi-specialty provider networks, and they might be more an appropriate level of aggregation for accountable care organizations or groups of physicians and hospitals that can collectively be held accountable for quality performance measurement and costs in implementing quality improvement initiatives. So you see here, these are smaller clusters that are sub-LHIN level of actual practice patterns by individuals and their physicians. A final area that I'll highlight today is examining resource utilization, intensity, and costs. So one particular finding that came out also of the physician networks analysis and related work was looking at higher spending hospitals and higher spending networks and how that impacted on readmission rates. So here we see spending is on the horizontal axis, the X. It wasn't an economist who did this. Readmissions are on the Y-axis. And we see a gradient downward where readmissions are actually lower in higher spending areas. And this gets at some of the intensity issue, that there's opportunities that actually turns out that places that spend more are getting something for it. Of course, the golden area is in the blue highlighted area where they spend less and have lower readmissions. There was another article in JAMA that was highlighted earlier today that found similar effects on mortality. The economics of care is a developing area of research at ISIS, and we've developed prices that are appropriate for each sector of the healthcare system, from home care visits to physicians and hospitalizations and acute care. The difference here is that we're not only looking at how much money is spent in a hospital, but how much money is spent for an Ontarian as they traverse the healthcare system. This here shows an example of early work that we did that built up the entire health system spending for 13 million Ontarians in 2007 and 8, and looked at the age, sex, in this case, just the age-specific spending. So we're spending most of our money, obviously, older ages associated with the multiple chronic conditions and the other disease issues. It also allowed us, when we looked at the health spending, to rank everybody in order of total system spending, with the highest people at the top and lowest spenders at the bottom, to identify that 1% of the spend, 1% of the population in Ontario use up 34% of the healthcare spending, and 5% use 66% of the healthcare spending in the province. The remarkable thing on the other end of this, though, is that 50% of the population used less than $181 in that year, and that 50% used up only 1% of the healthcare spending. But just looking at the population is not really where that will help us. I think it will help us most when we link up with the chronic disease work. And we link up with other population-specific work, and we can look at healthcare spending and quality across conditions for different people in Ontario. So for example, we can see here the far left is people with multiple ambulatory care sensitive conditions, chronic conditions cohort. And this is the healthcare spending in a year after a discharge from hospital. And we see in that population, there are a lot of hospital readmissions, and a lot of the care is being, or money in the system is being absorbed by hospital readmissions for that cohort. But stroke, which is right beside it, is another population. They have a very different trajectory through the health system as they travel from acute into inpatient rehabilitation, and then either out into the community with home care or often to long-term care. And so the interventions and how we work to improve quality with that population would be quite different. So I think it's enabling this linked with the other work. And next, well, maybe you'll have some ideas. I hope this summary pointed to some of the highly effective and policy relevant, and I think scientifically rigorous research that has been done by ISIS over the years in many topics of health care. Here I've focused on our approaches through health human resources, evaluation in emergency departments, the physician practices as well. And I barely touched upon the important work. I didn't talk about any of the practice variations work, which has obviously been very important. Perhaps now if we have some time, we just have some discussion about some ideas you think for expanding these in other areas.
Thank you very much.